Thank you, everybody. It's a pleasure to be here. And I want to thank Jeff from APLA for inviting me here. And it's just a privilege to be able to speak to you all. Just a little disclosure, my pronouns are she and her and hers. And I've come full circle. It's kind of full circle being here today. I'm a native San Franciscan. I am part of I'm the L in the LGBTQI community. Great to be here on Pride Month. I come from a closeted era, so it's like a big deal for me to say that out loud still. It's just really weird, you know. I am a native San Franciscan, and I was there in the 80s, but I was on the outside of the circle looking in. I was trying to figure out, do I want to be Catholic or do I want to be gay? And so I wasn't really out yet at the time, but I was, my sister was, and we were very involved and spent a lot of time in the Castro district, and I saw what happened during the HIV. I was more of a witness, but it was a horrible and a very dark time. And it's wonderful to be able to talk about long-term survivorship today, because at that time, nobody ever knew there would be such a thing. So I don't really have any money-making gigs on the side, except I'm on the scientific advisory board for a home health care committee. I want to dedicate my talk to a dear friend that we lost to AIDS, and this is his square on the quilt. So this is for Mike. So I'm going to point out 3 learning objectives today that you can use to fill your learning objective requirements. So describing 3 areas of cognitive difficulty in people with HIV in the current era. And I'll explain that. Describe 2 common mental health problems in older long-term survivors, but I think you've already heard a lot of that, but I'll talk about that to some extent. And 3 important steps for assessing cognitive change in people with HIV. So to really understand HIV and cognition in HIV, it's important to know about aging in people without HIV. So it's ironic, by the way, that we're talking about stigma today, and I'm a neuropsychologist, and I help diagnose people with stigmatizing disorders like Alzheimer's disease. But when I think of HIV, because I'm a major aging person, when I think of HIV, I think about what aging is a really good lens by which to understand cognitive difficulties that happen in people with HIV, and not to be stigmatized. And it helps people really kind of wrap their head around, well, what happens to cognition in some people who are long-term HIV survivors? So let's talk about what happens to people who are just aging in general. So I think of the brain very much like the knee, right? You don't have the same knee at 40 that you did at 20. And you don't have the same knee at 60 that you did at 40, and even at 60, it may be the knee you weren't born with, right? And the brain is the same. The brain changes with age. It's normal. It's natural. It happens. Thing is, we can't get a brain transplant. So we got to deal with what we have, right? The nice thing about the brain, though, is it's full of redundancy in the way the brain is organized. So we have a lot of backup systems, or a couple of backup systems in the brain that help us compensate for age-related and other kinds of cognitive changes as we age. Think about a stroke. Think about people who lose their ability to speak or lose use of an appendage, and they get better. They either improve, some people recover, some people partially recover. That's the brain rewiring itself. It's the backup systems that are coming into play and doing workarounds. And so this is a very important, this is called brain, it's resilience of the brain, it's reserve, it's the ability of the brain to sort of weather the storm and make some changes to adapt. So I want to start with that thought and leave that in your mind. what happens in just cognitive aging in general is if you think about cognition in two kind of camps. One is the stuff that we learn through our culture, through our life experience, through early education, through our careers and what we've done. That's called crystallized abilities. Those abilities really are very resilient to aging. They don't start changing until maybe the 70s or even later. And things like word knowledge, things like, who's Harvey Milk? Those are things that we know, that we keep with us for a long time. Some people think of crystallized intelligence or crystallized ability as wisdom. And certainly wisdom, I think, is how we use it. But that's a form of crystallized knowledge. The second is called, sorry, this is a term, sorry, let me go down. I'm giving you the wrong talk on the wrong slide. Here we go. The second is fluid knowledge. So fluid knowledge is new learning. It's how quickly our brain speed works. It's how quickly we can solve problems, think of words. It's our reasoning ability. So we call it fluid because it's like real flexible types of cognitive abilities. These are the abilities that change with age. And they start changing at a rather young age. So our speed of information processing start changing in the late 20s. So there's some good news for you. But we generally don't notice it, right? Because it's on the level of milliseconds. But we start noticing things probably when we get into our 40s and 50s. And then things start to kind of accelerate or get worse more quickly once we hit about 65. And that's when we're really feeling like, you know, what people call senior moments or you know, brain farts, PHARTS. And these are things that people will comment on. But again, this happens with aging. Now, what is not easy to figure out is when does it cross the line and when is it not aging normally or naturally? When does it become something that we have to worry about? And so this is when we talk about mild neurocognitive disorder and dementia. So dementia is a umbrella term meaning having significant severe cognitive impairment, and when we say severe, it gets in the way of living independently. So people that have dementia need help at home. They forget to pay bills. They may need help with their shopping. They shouldn't drive anymore. They're probably dangerous drivers. They repeat themselves a lot and don't remember, of course, that they may have asked the same question 10 minutes ago or forgotten what you told them 10 minutes ago. And because of these kinds of deficits or problems, they really shouldn't live alone, or they have difficulty living alone. They need help, like in-home supportive services, a relative or a friend helping them. They may also have social withdrawal, and they may have neuropsychiatric symptoms depending on the type of dementia, such as psychosis, hallucinations, things like that. The most common is Alzheimer's disease, right? That's the one that is the most common type of a dementia, but HIV falls under that umbrella. It has a different presentation, but it falls under that umbrella. In between dementia and just age-related cognitive decline is something called mild neurocognitive disorder. And that's people, those are folks that have more mild problems, and they may have complaints, they may have some challenges in daily life, but they can still manage. Maybe they put more effort into, you know, their jobs, or they have to use sticky notes more, but they're able to function. So typically that stage happens before somebody gets dementia. But people can have mild neurocognitive disorder for a myriad of reasons. HIV is one, but again, can be due to cerebral vascular disease, medication effects, depression. So you don't always know what's underneath, right, what you're observing. So that's the terminology I'm going to talk about and use today. Dementia and mild neurocognitive disorder, which refers to the kinds of problems that some people who are long-term survivors with HIV have. The other terminology is, if we can just be on the same page with who is a long-term survivor, which we've been talking about all day, but it's someone who's been living with HIV for many years, for a long time. But you can think about them differently, and I think cognitively it's relevant. So the first are the long-term survivors, people who've been having HIV for at least 10 years, and these are individuals who've been diagnosed after 1996, which is the advent of antiretroviral therapy. These are people that, in theory, would have had access to these medications, and in theory, would have had less exposure, if they get onto the medications, of HIV, to the central nervous system. Then there are the longest term survivors, and these are our fellows and fellow survivors who've been living with HIV, who seroconverted before 1996. And so these are individuals that had no access to medication because it didn't exist. And these are individuals who may have been on some of the more harsh forms of early medications that may have had side effects. And these are the individuals, as we have heard today, who have been through the darkest times of HIV and who may carry with them the trauma of having been through that. And we talked about that today as how much of that was triggered from COVID. Then there's a third group of folks who've been living with HIV their whole lives from birth or from very early childhood, either because their mothers had it and they got it either in utero or through breast milk, or someone got it very early in life after they were born. And this is a brain that is developing in the context of HIV virus. So I'm not going to talk about people that have had it since childhood, but just to be aware that when we talk about long-term survivors, not everybody is alike, even in that description. So what about people with cognitive problems related to HIV? So we call that HIV-associated neurocognitive disorder. Some people may have heard of it as the Frascati criteria. That's not important, but that was a group of people that actually set the criteria, named it. But HAND is a spectrum of cognitive, motor, and mood problems collectively known, right, as HAND. And it excludes other causes of cognitive impairment, which is important. About 50% of the people with HIV have mild cognitive difficulties. And that's about the same prevalence that had difficulties pre-CART, but the difference is that pre-CART, you had about 50% of the people with dementia. With post, right, in the era of CART, the percentage of people with dementia is about 2%. And people have much milder forms of cognitive difficulties now, thank you to all the antiretroviral therapies. So in fact, HIV patients who are diagnosed and managed early, they have a lower prevalence of HAND compared to matched HIV uninfected persons. So in other words, if people with HIV get treatment, as we've been hearing today, you have a very good chance of living a long, healthy life. But there are still about 50% of people who develop some degree of cognitive difficulty. So if you look at the three types of HAND, okay, so they divide it into three types. One is people are asymptomatic. They're like, well, why do they have HAND then? Well, that means that HAND is based on how people perform on neuropsychological tests. And so what they found is there are people with HIV who perform one standard deviation below the mean, so in the lower percentiles, on at least 1 or 2 tests, but they don't feel like it's causing them any problems in daily life. I don't even know why they consider that a thing, but that's controversial, and they call that ANI, asymptomatic. But then there are folks who are asymptomatic. They perform about at that level, and they're struggling a little bit in daily life. They have mild functional impairment. That's about 12%. And then about 2% of folks with HAND have the severe form where they become dependent and need help and have dementia, and that is the AIDS-related dementia. I'm going backwards. Never do that. Okay, so what are the risk factors for HAND? Well, research studies have been conducted, meta-analyses and different individual studies that list these factors as risk factors, and these are cross-sectional studies. These are where you look at people one point in time. So one is having low CD4 nadir, meaning like the lowest CD4 is very low, like 200 or less. Medication not adherence, not taking meds regularly. That is a biggie. Okay, older age, we talked about. We talked about the cardiovascular risk factors, hypertension, high cholesterol, more depression, maybe histories of head injury, having had toxoplasmosis in the past, possibly, and detectable HIV in the plasma, so that, meaning that they're not, they're not getting the full benefit of meds, and maybe a lifetime history of methamphetamine use. So these are conditions or disorders or conditions that seem to be risk factors for HAND. But definitely the most important is people who are having difficulty adhering to their medication regimen. Now, before CART, the neuropsychological deficits that were seen in people with HIV were motor, a lot of psychomotor slowing, slowed down word retrieval. People were very slow, and they said they kind of remind you of somebody with Parkinson's disease, and that they're all slowed down, and these were considered to be associated with what they call subcortical problems in the brain. So problems deep in the brain, in the basal ganglia, areas that are below the cortex that are typically affected in Parkinson's. This is what they were kind of comparing it to. After CART therapy, the profile of HAND seems to change on neuropsychological tests. So people seem to have trouble more learning new information, looking more like Alzheimer's disease, but it's not the same. But having trouble learning new information, having more difficulties with reasoning, which is an executive function, a very high level cognitive function. And so reasoning is another. A third one, it's not really a cognitive problem, it's more of a neuropsychiatric symptom, is apathy. Apathy meaning low motivation, I wouldn't say not caring, but it's sort of like not caring, but it has nothing to do with somebody on purpose not caring. It's just not being as worried about something. So maybe you take your meds, I missed them today, oh well, tomorrow's another day. So people with apathy have trouble following through on recommendations that you may give them, or even have difficulty picking up the telephone, right, and making an appointment with you. They might have trouble with hygiene and taking good care of themselves. So, but apathy can be a symptom of someone with HAND. So decision-making problems have implications as well for health and safety. And one of those might be sobriety, right? Same thing with apathy. You're like, no, I can't drink, or no, I can't take that substance. But if someone has poor judgment, their reasoning is off, or they have apathy, they might make a bad choice in that situation. And another one is working memory. And working memory is being able to remember what somebody is saying or what you're reading kind of online. And if somebody is talking to you and they're telling you a story, if you have a working memory problem, you're going to forget the beginning of the story, or you might forget the middle of the story. You have a limited capacity to keep that all in your head at once. And people with working memory problems will have trouble learning new information because they have trouble taking information in. So can you imagine somebody with this problem and you're trying to help them in your, your office or your clinic, and you're talking to them and you're giving them recommendations? What do you think could happen?
They get overwhelmed.
Yes, they get overwhelmed. What else? Can't remember. Confused. Miss stuff that you're telling them. And then you might, not you directly, but their clinician may think, or their social worker or case manager might think, why aren't they listening? What's the matter with them? And it's like, maybe they can't. Maybe there's a cognitive issue there. So, and the awareness, someone's awareness of that may be limited. So another question is, so does hand persist over time? And I wish I could tell you yes or no. But the research shows mixed results on this. And probably one of the best studies I've seen, which is a longitudinal study, comes from San Diego, Bob Heaton, and he has been following populations with HIV since the late 80s. And so they did a study where they took people that came into their clinic, they got all baseline assessments, cognitive testing, lab work, and then they come in periodically for a reassessment, and he followed a subset of those people over 12 years. And he looked at the team looked at their testing over time. So in that study, they found that some people progressed over time, some people were pretty stable over that 12 years, and other people actually, a smaller percentage, actually improved. And the people who do the best are the people that are adherent to their HIV meds, that they have controlled HIV, right, in CSF, right, cerebral spinal fluid and plasma. And but treatment cannot entirely essentially predict or predict that somebody will not progress, but those are individuals that have the best odds of staying healthy, cognitively healthy over time. So this is a study, and again, these are very comprehensive. It was a diverse sample, it was a large sample, and their neurocognitive battery was comprised of 15 different tests. And this is the average age at baseline was about 40, and then again, age in 12 years when they followed up was in early 50s. And then they had another group that they divided them into young and older. Their baseline was 50, and they were about 64 when they were retested. So what did they find in the study? They looked at not only people's score, they did a composite score based on all the tests, but they also divided people into folks they called decliners, people that got worse, and people who didn't get worse. They stayed about the same. And the take-home message here is the greater cognitive decline was seen in people with the greater number of comorbidities, who had these comorbidities at baseline and at follow-up. So remember in our talks prior to today, we talked about cardiovascular comorbidities, hypertension, high cholesterol, and other conditions. And so what these graphs show on the top, it looks at their score, which is on the vertical axis. Negative numbers mean more change in the bad direction, right? And it looked at their scores at baseline and at 12 years by the number of comorbidities. So the higher bars, right, mean more decline. And the people that had most decline are folks that had 3 or more comorbidities. The bottom 2 graphs, again, baseline and follow-up, show the proportion of decliners by the number of comorbidities at baseline and 12 years. And again, take-home message is, if you look at the ends of those graphs, the highest proportion of decliners were the people that had the most comorbidities. So age didn't seem to be a factor. Everybody declined. So the older people in the study didn't seem to decline any more than the younger people in the study. And CART wasn't a factor, but they couldn't really answer the question about does drugs help in this study, because everybody was fairly well controlled, right, and on CART. But again, cardiovascular disease, chronic pulmonary disease, neuropathic pain, all the things we've been hearing about all day, and again, evidence of liver injury. We have frailty, depression, and anemia. So Dr. Young Karras talked about premature aging, and I think we may have, maybe Dr. Nash, somebody talked about premature aging today. And there's a hypothesis that yes, HIV is like premature aging. So this is what I'm talking about, aging being a good kind of context, or a lens, is that very similar, parallels are happening, but they seem to happen younger in folks with HIV, but the same types of comorbidities are happening. And so the evidence of physiological aging appears earlier in people with HIV than in the general population. And the prevalence of those age-related diseases, diabetes is another one, is higher. And so, one concept is that there is an accelerated aging process, and it seems that the culprits could be inflammation and chronic stress. And one of those stresses is psychosocial stress, right? And the stigma, the discrimination, the history, and other types of stress, like trying to keep up with the medication regimen, all these that, involved in disease management may be contributing to getting more depressed, then people not adhering to their ART, which leads to the vicious cycle of getting then more inflammation in the body, etc. And then again, more age-related comorbidities. So that is one hypothesis. I'm going to talk just a little bit about mental health because we've already heard about it, but I just want to reinforce the message that people with HIV do have higher rates of mental health problems, especially depression and anxiety, substance use, and PTSD or age survivor syndrome, the why me? Why am I still here? Right? Guilt, etc. They didn't feel like they should have lived this long. And this stays with people through the years. So the longest term survivors are especially prone to this. And you think again, we talked about Mr. Cassin's presentation about how many people lost family and very good friends, and lots of them. So this all contributes to mental health challenges. But the big ones are, the ones that we worry about when you're seeing somebody is the depression, right? But it can lead to other problems too. There could be medication non-adherence, sexual risk-taking, use of substances, low self-esteem. So what do you do if you see someone in your office and you're seeing them for the first time, or where am I going? And or you're seeing them over time, numerous times. So do people actually have clients in their office that they see? and talk to. Do you assess for depression? What do you do for the assessment of depression? Does it ask questions? What was that? Okay, you use the PHQ-9. Okay, great. Does everyone know what the PHQ-9 is? No. Okay, good, because that's gonna be part of our lesson today. So, a quickie, but we're gonna do it. So, can you see that? Okay. PHQ-9 is something that's available. It's free, and it asks very, I would say, intuitive and questions that cover symptoms of depression according to the DSM, Diagnostic and Statistical Manual, but in a way that people can relate to and understand. And so if somebody endorses a certain number of these items and severity that have to do with sleep, that have to do with appetite, have to do with feeling hopeless, depressed, and then if anyone is thinking of taking their lives, it assesses for that, like thoughts they'd be better off dead. If you get a certain score, then that means that it's a red flag, and that person there should be some follow-up on that person, right? Either somebody referred to psychiatry or their PCP or to a therapist, depending on the situation. If someone endorses suicidality in your office, then what do you do typically? Does anybody take further steps? What do you do? Well, what do you have? Well, you could do 5150, but they have to meet the criteria for that, right? So what are you looking for? You're looking for plan,
active, access to a weapon or something.
right? Means and imminence, right? Thank you. So that's what you need to be looking for, and depending on how people answer those questions, right, is going to determine what you do next. So if they say yeah, I just wish I would end it all. Well, have you thought about how you would do that? No, I just think someday it might get too much for me. So that's different than, yes, I don't think I can take anymore, and I don't know, I'm just on the verge. And do you have means at home? Maybe they have a weapon, maybe they've been stockpiling meds, maybe they want to drive their car into a tree. But again, means, right, plan, and imminence. And then for those folks, you would take action accordingly. For cognitive abilities, the time to screen for that, think about it, is when you first start working with someone, right? Periodically monitor their cognition over time, maybe once a year if they don't seem to have complaints, or every 6 months, depending on if they have difficulties already. If you suspect by their behavior that they're forgetting appointments and forgetting to follow up with you, that would be a reason. If they're complaining to you, that would be a reason. If you're seeing a collateral or they're coming in with a friend or relative or partner and that person is saying there's been a change, that would be a reason to initiate a cognitive evaluation. There's a few different ones out there. I really like the MOCA, to be honest with you, and that Dr. Karras was talking about. You have to get, we don't have time to teach it today, but I gave you the website for it. It comes in multiple languages. It's validated for mild cognitive impairment and dementia. Once you get certified, then it's free. But I'm going to give you an instrument today called the International HIV Dementia Scale. Now, this is for people that it's going to determine or flag people with more severe cognitive impairment. With any testing, though, you have to be mindful of who is sitting in front of you. and whether that test is going to fairly assess that person. So people with English as a second language, people who are not as familiar with the culture, people who have lower education, those are individuals that are going to look worse on a test by virtue of maybe not speaking English well, not being able to hear you, things like that. So this is something that you have to be very mindful of when you're testing. And again, if you have a primer in how to give cognitive testing, I would advise that you have someone come in and talk to you about these things. But definitely always ask if someone is having a problem. Always observe how they're doing in your office. If you can gather collateral information, that's important. And then screen, and if their screening is concerning, then you can rescreen, or you can refer them for more comprehensive testing or send them to their physician. So let's look at your HIV dementia scale. And I gave you 2 handouts. One is the actual scale, and one is this slide. Okay. Let's talk about the first item. The first item is you're going to ask somebody to learn 4 words. Do you have that? Okay. And you're going to follow the instructions verbatim. So you're going to I'm going to ask you to learn 4 words, and you're going to read them to them at the rate of about 1 per second. So it would be dog, hat, bean, red. Repeat those 4 words to me, please. Okay, great. Now I'm going to ask you to remember those words, because I'm going to ask you to tell them to me later. The next thing you're going to do is assess motor speed on the non-dominant hand, meaning if they're right-handed, it's going to be their left hand. And you're going to ask them, can you all flap? Okay, you're going to ask your patient to flap the first 2 fingers on the non-dominant hand as widely and as quickly as they can for 15 seconds. And you're going to, for 5 seconds. And they have to get so many taps in that time. So if they get 15 in 5 seconds, they get 4 points. If they get 3 to 6 in 5 seconds, as you see on the slide, they get 1 point, right? If they can't do it, they get 0. So that gets at the motor speed and whether somebody is stiff, not coordinated. The next is psychomotor speed and sequencing. This gets to executive function as well. And you're going to ask someone to do a motor sequence. So everybody go on your table, and they want you to do fist first, then flat, and then edge. Fist, flat, edge. Fist, flat, edge. Fist, flat, edge. Keep going. Keep going. Okay, great. And so those people need to get 4 sequences in 10 seconds. So you're going to need what for this? A timer, right? A timer or your iPhone or whatever. If they can't do 4 in 10 seconds, if they give you 1 in 10 seconds, that's 1 point. Some people can't do this. They struggle, they do this, and they get it wrong. They give you half movements. That's what happens when someone has problems. And then I'm going to ask you, what were those 4 words? Okay, and so you ask them to repeat the 4 words, and if they cannot give them to you, then you can give them a clue. So if you look on the form or on the slide, a dog is an animal, right? Then they'll say, oh, I can't remember. 1 was a piece of clothing. All right, 1 was a vegetable. 1 was a color. And again, you give them points according to how many they get. So this test is like sudden death. If you miss 2, it's a red flag. If you only get, if you only get 2 points, if you get 2 wrong, so you get 2 wrong out of the full points, then it is a red flag, and that means that somebody should be referred. So does it mean that they have dementia? No. And your job is not to diagnose somebody with dementia. Your job isn't to even diagnose hand, because that requires a number of tests to rule out all other things that could be going on. Because remember, hand has to be caused directly by HIV on the brain, and that is not an easy thing to do, because in older adults, there are lots of things going on that could cause these mild cognitive changes. So that all has to be ruled out or understood until somebody can make a diagnosis of hand in someone. But your job is to identify that somebody that needs treatment or needs more assessment. It's also going to help you understand what kind of help somebody needs at home. So to wrap up, do they need assistance with their appointments? Do they need follow-up phone calls, right? And do they need somebody to assist them so you can help them, or do you need to help them more so they can meet the goals of care? Any questions?
Can you do all three at the same time?
Do all three what?
All three tests?
What do you mean?
Like your dog being half dead and like you.
No. Just do it with the non-dominant hand. I mean, if you want to, then you're a show-off. You're like, show-off, show-off. But this is a screener. Again, to wrap up, I really recommend, if you want to do something more sensitive, learn the MOCA, have somebody walk you through it. And what you should do is read these instructions verbatim and practice with somebody. Who owes you a favor? Practice with that person. Okay, so I want to thank you all. Thank you for the good work that you're doing. Okay.
Thank you.